Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the 7th sessions of the Peer Learning Periphery to the Fore 2023 online case discussion by physicians away from the center. My name is Dr. Rohit Amaravitarana, the moderator of the today event. We know that the physicians working in outstations with limited resources have evolved excellent clinical skill in patient management. So there's a lot to be learned from them. Peer Learning Periphery to the Fore is a platform for physicians who work away from the center to share their knowledge and experiences with us. In this session, 2 physicians present and discuss clinical cases in 1 hour period. Today, we have 2 consultants from Base Hospital Mayangane and District General Hospital Ambilipitia. At the end of the both presentations, we will discuss the questions. Please send your questions to Q&A box. Let me to introduce the first speaker today, Dr. Gayani Samaratunge, Consultant General Physician, Base Hospital Mahiyangane. Dr. Gayani Samaratunge, MBBS, Ragama, MD Colombo, Overseas Training at Queen's Hospital, NHS Foundation Trust, UK. She is going to talk on an uncommon case of recurrent pancreatitis. Dr. Gayani.
Yeah, so today I'm going to discuss about an uncommon case of recurrent acute pancreatitis that I have encountered within last few months. So without delaying, I'll go to my case. My patient is Mr. A, who is a 47-year-old gentleman from Mahiyangana and presented to the surgical ward initially on 2023 April actually. And the initial presentation, he was having severe epigastric pain, vomiting, retching, and backache. The features were typical of acute pancreatitis. It was an occasional alcohol intake, a non-smoker. There was no associated trauma to abdomen, and he did not give a significant past medical history or family history at that particular time. And examination was unremarkable except for the tender abdomen with guarding, and he was hemodynamically stable. So the ultrasound scan abdomen was done, and it confirmed the diagnosis of acute pancreatitis. He was treated accordingly with IV antibiotics, recovered and discharged. And at that time, there was no further problems. After 2 weeks, interestingly, again, the patient presented with the very similar presentation, again, treated as the same diagnosis and discharged. And after another 3 weeks, the patient has presented exactly with the same clinical picture. And at that point of time, the surgeons were wondering what's happening here, because now this was recurrent acute pancreatitis, as the short term referred it as RAP. And hence he was transferred to DGH Badulla for further investigations with CECT abdomen to find out what's really going on there. So the CECT abdomen and pelvis was done. Acute pancreatitis was confirmed with peripancreatic inflammatory collections, and pancreatic ductal dilatation was observed with pancreatic duct calculi. Interestingly, there were some additional findings. There was nephrolithiasis and medullary nephrocalcinosis, and there was evidence of early CKD. And at this point of time, the patient's serum creatinine was marginally high as 1.8. The patient got scared and went to the private sector, but he was unable to afford for the full profile of investigations and the things. Fortunately, the MRCP was done, found to have a calcific stone in main pancreatic duct, partially obstructing it. There were no pancreatic tumors. There was no malignant hilar or perihilar obstruction. There were no common duct stones, as well as there was no gallstone pancreatitis. There was no other significant findings. So interesting thing is, most of the patients with RAP, recurrent acute pancreatitis, usually have gallstones, or they would have a pancreatic malignancy, or there should be some perihilar obstruction, the ampulla of Vater obstruction. So interestingly, this patient didn't show any gallstone pancreatitis. But the only finding that was significant was the partial obstructing calcific stone, which is not a gallstone. So surgeons were wondering what's really happening. So anyway, the patient was referred to the medical clinic because this patient was having nephrocalcinosis, nephrolithiasis with early CKD. So this is the summary of investigations done at surgical ward. See, the amylase was 776 initially, raised up to 2,500 by the end of the third admission. Serum calcium was done persistently and it was normal. Serum creatinine, marginally elevated. Fasting blood sugar, completely normal. CRP high because of the pancreatitis with neutrophil leukocytosis. Serum triglycerides, again normal. Interestingly, additional finding, serum potassium was low as 2.4, raised up to 3.3 with potassium chloride 2-tab TDS. That was the maximum they can gain. So now there's a patient presenting to me in the medical clinic with RAP, recurrent acute pancreatitis, and found to be having nephrocalcinosis, nephrolithiasis, and interestingly, low potassium. So what's going on? So I had to start from one end because the nephrocalcinosis was the most important problem as it has led to early CKD. I started there. So let's see what nephrocalcinosis is. Nephrocalcinosis is a generalized calcium deposition in the kidneys. This can be calcium phosphate or can be calcium oxalate. And this is usually associated with nephrolithiasis, and patient usually presented with both conditions. So this can lead to acute or chronic kidney injury. And this is caused by either hypercalciuria, hyperphosphaturia, or hyperoxaluria. But the commonest one is actually hypercalciuria. So now I was wondering what's happening with my patient and what is the possible cause for this patient nephrocalcinosis. So try to find out causes, and nephrocalcinosis is mainly divided into 3 categories. That is hypercalciuria with hypercalcemia, hypercalciuria without hypercalcemia, and hyperphosphaturia. And additional to these, there can be hyperoxaluria and hypocicraturia as well. But it's not a very common cause for nephrocalcinosis. Obviously, hypoxaluria and hypocicraturia are real causes for nephrolithiasis, but it does not commonly lead to nephrocalcinosis. So if it is hypercalciuria with hypercalcemia, the major causes are the causes causing the hypercalcemia, such as primary hyperparathyroidism, sarcoidosis, vitamin D therapy, and milk alkali syndrome. If it is hypercalciuria without hypercalcemia, can be distal renal tubular acidosis, medullary sponge kidney, and some inherited tubulopathies such as Bartter syndrome, hypermagnesic hypercalciuric nephrocalcinosis, and autosomal dominant hypocalcemia. In certain incidences, some of the chronic hypokalemias can also lead to nephrocalcinosis. And the identified ones are primary hyperaldosteronism and Little syndrome. There are a whole lot of causes for chronic hypokalemia, but all of them do not lead to hypercalciuria. In hyperphosphaturia, the possibilities are hyperphosphatemia due to any cause. Name it, it can be tumor lysis syndrome, maybe iatrogenic phosphate intake. And certain inherited tubulopathies like Dent's disease, maybe malignancy, and maybe renal transplant. So now I have identified the causes. I'm with the patient. I'm going to find out, I tried to find out what's happening to my patient. So I went back and get an extended history, examined him, and investigate him as much as possible. So in my patient, there were no hypercalcemia features. He was without any constipation or any significant abdominal pains other than this recurrent pancreatitis. There was a past history of urolithiasis. He was investigated and then he defaulted. He was not on any drugs which can cause nephrocalcinosis or nephrolithiasis, as I have mentioned. There was no evidence of cardiac failure, no exertional or resting SOB. There's no past or present history of hypertension, and BP was completely within normal range during the examination. And there was no history of hematuria. There was no evidence of any paraneoplastic syndromes to suggest malignancies. Now, this is where the interesting thing really starts. He came without any records. But with repetitive questioning, he came out with a history of acute bilateral lower limb paralysis in 2015, for which he was treated with an IV medication and completely recovered within few days. He defaulted to the follow-up, but managed to take the same oral medication given on discharge over the counter, but that was occasionally. And it has been going on for last 8 years. Family history. Elder brother again had a similar type of lower limb paralysis, and he is also taking the same type of drug. Then I kindly requested him to come with the medical record. With difficulty, we found it. In 2015, he was managed in Mahayangana Hospital as hypokalemic periodic paralysis and found to be having 3 small calculi in right kidney, but there was no nephrocalcinosis. Investigating him, found that serum potassium was as low as 1.6. Drugs were not taken at that time. Serum sodium was normal, 135. Serum chloride was marginally upper normal, it was 111. Serum calcium, serum phosphate, serum magnesium, all 3 were normal. Arterial blood gas done. pH 7.28 with a bicarbonate of 14. And base deficiency was minus 11.2. Anion gap calculated, it was 10. So this was normal anion gap metabolic acidosis. Proceeding with the investigations, went for the urine pH. Expectation was to have an acidic pH because the patient is having a normal anion gap metabolic acidosis. So anyone with normal anion gap metabolic acidosis or whatsoever the metabolic acidosis, the pH should be less than 5.3. But my patient's pH was 5.7 in urine. Albumin was 1 plus attributed to the early CKD. Interestingly, urine calcium was 7.8 and the cutoff was 7.5. Urine phosphate was normal. Urine sodium, urine potassium, urine chloride done, and urine anion gap was calculated 7.5 and it was positive. So now I've got a patient with nephrocalcinosis, nephrolithiasis, hypokalemia, early CKD, and the above investigation showing normal anion gap metabolic acidosis with high urine pH, alkaline urine pH. So we are going to exclude certain causes. My patient never had hypercalcemia. There were no features suggestive of sarcoid, and there was no vitamin D therapy, no history of milk alkali syndrome. So we excluded that part. There was no evidence of malignancy, never undergone on any renal transplant. There was no evidence of hypophosphatemia. And the serum phosphate was normal, urine phosphate normal. So we excluded that part as well. The remaining 4 causes are there. Undergone on CCT abdomen already by surgical site. If medullary sponge kidney were there, it would have been already identified. Excluded. Inherited tubulopathies, something like Bartter syndrome, will give rise to metabolic alkalosis with hypokalemia. My patient is having hypokalemia, but there's normal anion gap metabolic acidosis. It's not possible. Sorry, let's go to chronic hypokalemias. So chronic hypokalemias, my patient's blood pressure was persistently normal, and CCT abdomen didn't show any consadenomas or bilateral adrenal hyperplasia suggestive of primary hyperaldosteronism. There would have been some clue if he's had primary hyperaldosteronism. So that's not possible. Pligal syndrome, again, will give rise to hypertension, which my patient didn't have. Metabolic alkalosis, again, my patient didn't have that. So that's not possible. Bartter syndrome, as I told, is a condition that is causing metabolic alkalosis, which is very unlikely. My patient's serum magnesium was normal, and my patient's calcium was persistently normal. So I'm left with possible one diagnosis, distal renal tubular acidosis. So I was trying to find out whether he's having that. So let's go back to the patient's investigation. My patient is having normal anion gap, metabolic acidosis here, with urine pH 7, arterial blood gas pH 7.28, anion gap 10, urine pH 5.7, which is quite alkaline for this type of acidotic patient with hypercalciuria. So this led to me think that this patient is having distal renal tubular acidosis. So let's talk a bit about renal tubular acidosis. Renal tubular acidosis is a group of disorder that causes systemic acidosis, and the primary problem is there in the renal tubules. And it is due to the impairment of the ability of the renal tubules to maintain the acid-base balance. So as we all know, there are 4 types. Type 1, the proximal renal tubular acidosis. Type 1, the distal renal tubular acidosis due to the decreased renal hydrogen ion excretion. Type 2, the proximal renal tubular acidosis due to the renal bicarbonate loss. The type 3, the mixed one. The type 4 due to the primary hypoaldosteronism, which will lead to hyperkalemia. So, the primary pathology in distal renal tubular acidosis occurs in late distal convoluted tubule and collecting ducts. So this is a very interesting paragraph, picture actually. So imagine now this is the alpha intercalated cell, this is the principal cell, and this is the beta intercalated cell. This is the distal convoluted tubule. So, sorry. Now, there are certain pumps that will secrete the protons into the tubular lumen. So there are 2 pumps, HATPS, which is an energy-dependent proton pump, and there's an exchange, potassium hydrogen ATPase exchange, which takes in the potassium into the cell and excrete the hydrogen. And there's another one maintaining this balance that is called AE1. So any 3 of these or combination of them, if any of them or all of them is dysfunctioning, the patient can develop the distal renal tubular acidosis. So let's see what's happening. Imagine this H+, if this pump is not working, if this H+ will not be excreted, so it will go into the blood. This one not working, the H+ again will go into the blood. And if this H+ is not excreted, this potassium cannot be reabsorbed. So what will happen is it is wasted. And imagine if any problem coming on here, there will not be any bicarbonate reabsorption into the blood, and that will cause some electroneutrality problems. And again, the hydrogen ion secretion will not be that efficient. So, as I told, it can be due to any of these 3 pumps problems, HATPase, hydrogen potassium ATPase, or AE1, but actually the energy dependent HATPase is the most common cause. Rarely there's defect in inert transporter, which is in principal cells, but I'm not going to talk details about it. So what will happen is the blood is becoming acidic because the renal tubule cannot secrete the protons to the lumen. There's no H+ in the urine, urine become alkaline, blood is becoming acidic. This is very unlikely of any other acidosis. Any other acidosis, the urine is trying to become acidic to compensate for the metabolic acidosis. But in this case, it cannot happen, and the urine is persistently alkaline, and it will never acidify beyond 5.3. So the urine pH will always be above 5.3. So these conditions will give rise to hyperchloremia as well. So let's see how it causes hyperchloremia. Obviously, when the protons are retained in the blood, it should be neutralized by bicarbonate. So otherwise, the electroneutrality of the blood cannot be maintained. So once the bicarbonate goes down, there should be some other anion retained to make the electroneutrality. So the only anion that can remain is chloride. So these patients are becoming hyperchloremic metabolic acidotic people, and that is why the anion gap is normal. And there are certain mechanisms that can cause hypokalemia. First thing is that if tubules are not secreting hydrogen ions into the tubule, there should be another cation who is going instead of it. Urine cannot remain without cations. So if you are not giving hydrogen, it should be someone else going on. So that the only cation, the common one remaining is potassium. If hydrogen is not going out, potassium obviously has to go out to maintain the electroneutrality. Other thing is, as I told, if hydrogen potassium ATPase pump is the primary disorder, then obviously hydrogen will not be reabsorbed, will not be secreted, and potassium will obviously be wasted. So let's talk about a bit about urine anion gap as well. So any patient, any normal person, the excreted urine sodium and urine potassium is higher than excreted urine chloride. So any of us is having a positive urine anion gap, and it's usually between 20 to 90. In metabolic acidosis and in hypokalemic conditions, the body is trying to increase the ammonia genesis from the proximal renal tubule, because this ammonia can bind H+ and make ammonium, NH4, and later NH4 will be combined with chloride ions and it will be excreted. So this is one way of buffering off the hydrogen ions or the protons from the body. If one is having metabolic acidosis, one of the best thing to do is make more ammonia, make it ammonium chloride, and send off the hydrogen away. But so in such conditions, as the chlorides are getting more and more excreted in the urine, the chloride value here will go up. So any patient with acidosis should have negative urine anion gap, because more ammonium chloride formation will lead the increased chloride ions in urine. But in this condition, even the body is trying to compensate, H+ cannot be excreted from the distal convoluted tubule and the collecting duct. So there will not be enough protons to make ammonia to ammonium. Hence, there will be less ammonium chloride production. So still, the urine chloride will be reduced. So still, the patient urine anion gap is positive, as in my patient. So despite the metabolic acidosis, these people are having positive urine anion gap. So let's see what is causing the nephrolithiasis and nephrocalcinosis and other stones. Several mechanisms have been identified. The very first one is that increased calcium phosphate release from the bone because of as a buffering mechanism. Second one is hypercalciuria due to direct reduction of the tubular reabsorption of calcium. And the third one is high urine pH favoring the precipitation of calcium phosphate. And there will be radiate citrate excretion as well. Radiate citrate is an excellent inhibitor of calcium stone formation. But what happens is, acidemia enhances proximal citrate reabsorption, so there will not be much citrate remaining to come into the distal convoluted tubule. So it causes hypositraturia. So I was trying to find out what are the possible causes for my patients. Distal renal tubular acidosis. His brother was having a similar history, and unfortunately, I didn't see that person. And so we thought it's most possibly a primary cause, but we were interested in exploring the secondary causes as well. So the possibilities are Sjogren's syndrome, autoimmune hepatitis, primary biliary cirrhosis, SLE, and rheumatoid arthritis. Certain drugs like amphotericin B and lithium carbonate, some hypercalciuric conditions with hypercalcemia, and some genetic conditions like Marfan's, Ehlers-Danlos, and medullary sponge kidneys, and certain rare causes such as obstructive uropathy, renal transplant rejection, and Wilson's disease. So, went back and re-evaluated my patient. I'm sorry, I forgot to tell, actually, some hypergammaglobulinemias also can lead to distal renal tubular acidosis. As the PBC and SLE and lot of liver diseases, autoimmune hepatitis, those things can lead to distal renal tubular acidosis. We found out whether the patient is having any evidence. Actually, the full liver profile was normal. Ultrasound or CCT abdomen didn't find any possibility of cirrhosis. He didn't show any autoimmune disease features. There was no painful thyroid enlargement. It was clinically euthyroid. TSH was normal. ANA and ultrasound scan thyroid still pending. And he didn't show any collagen disorder features. And as I told, he had persistently normal high blood pressure, and there was no feature suggestive of medullary sponge kidney in the CECT. So most of the causes we have suggested here were excluded. So we thought that it's most possibly something like autosomal dominant defect. So how we are going to treat this type of people? So distal RTA, you have to treat the primary disorder. If it is autoimmune hepatitis, treat the disease and treat the symptoms. So treating the symptoms, correct the metabolic acidosis. This will give a lot of benefits. It will minimize or it might reverse the nephrolithiasis and nephrocalcinosis. It will diminish calcium loss as a buffering mechanism, and it will reduce the osteoporosis as a consequence. There will be inappropriate urinary potassium losses in distal RTA that will be reduced with this therapy, and it might correct the hypokalemia as well. But meantime, we must remember we should not alkali the urine too much. We should avoid excessive urinary alkalization, especially in nephrolithiasis and nephrocalcinosis patient, because the higher the urine pH goes, higher the stone formation. So it is the alkali therapy we are going to use here is a double-edged sword. I'll discuss it, and we have to be very cautious about it. So sometimes we might have to administer KCL as well if there's ongoing potassium loss, which is not corrected with alkali therapy. So I'm going to talk a bit about alkali therapy. So what are we going to give as alkali therapy, how we are going to give, what's the dose, and how we are going to monitor. So the aim is to achieve the normal plasma bicarbonate concentration, the lower limit, the 22 milliequivalents. And potassium citrate is the preferred agent. So let's see why it is preferred. Because potassium citrate will be rapidly metabolized to bicarbonate and will alkali the urine. Meantime, it will increase the citrate concentration in urine and reduce the hypocitraturia. So it is beneficial in both ways. So it is the preferred one in stone formers. So we start with initially 20 milliequivalents per day, and then we are increasing it up to 30 to 40 milliequivalents per day till we reach the urine pH of 7.5 with urinary citrate excretion exceeding 450, or till there's a significant reduction in urine calcium excretion. But after that, we have to reduce the alkali therapy to prevent further increase in urine pH. But in certain conditions, you might have to discontinue it early to prevent worsening of nephrocalcinosis because sometimes the urine pH might rise without substantial increase in urine citrate excretion or a reduction in urine calcium excretion. In that type of patients, you have to cut off the therapy by urine pH of 6.5. In non-stone formers, you can start treatment with sodium bicarbonate or sodium citrate, but you might need potassium citrate as an additional therapy if the hypokalemia is not corrected with alkaline therapy. So how we managed our patient? My patient was initially on KCL, intermittent therapy. He took it over the counter. We stopped it. Start with potassium citrate 20 milliequivalents, that is 1080 milligrams BD. And we checked the plasma bicarb, potassium, and urine pH. Bicarbonate concentration increased from 14 to 18. Serum potassium was 3.4, urine pH was 6. After 2 weeks, there's certain improvement of urine pH from 5.7 to 6. Then we increased the citrate dose, and we are going to do the serial urine pH and urine calcium excretion tests. We are trying to arrange a DEXA scan to assess the osteoporosis. ERCP will be arranged from the surgical side. It's already arranged actually, and we are proceeding with the remaining investigations. So I would like to discuss what are the problems we encountered. The patient was extremely poor financial support. So he was unable to spend much on expensive investigations. And unfortunately, we were unable to do the urine electrolytes, urine calcium, phosphate, and see the magnesium levels at hospitals. Sorry. So, and the other thing is potassium citrate was not available in government sector. And so pharmaceuticals company sponsored for his drugs. And we are unable to perform urine citrate excretion in Mahayangana. So we have to merely guide the alkali therapy with urine pH and urine calcium excretion. I'm sorry. So thank you so much for your valuable time. And this is where I work. One of the most beautiful places I have seen in my country. Thank you so much.
Thank you very much, Dr. Gayani, for very interesting and very informative presentation. So we will come to the questions at the end of the next presentation. And let me introduce the next speaker today. The next speaker is Dr. Lalana Devi Ranasinghe, consultant endocrinologist, District General Hospital, Ambidipitiya. Dr. Lalana Devi, MBBS Colombo, MD Colombo, MRCP UK. Overseas training at Cambridge University Hospital, Cambridge, UK. She is going to present on thyrotoxicosis in pregnancy. Over to you, Dr. Lalana.
Dr. Rohita and Ceylon College of Physicians for giving me this opportunity. So moving on to my patient, this is a 35-year-old pregnant lady at a period of amenorrhea of 8 weeks, referred to me by the obstetrician for further management of thyrotoxicosis. At that time, patient was feeling well, no thyrotoxic symptoms, and she has noticed that her eyes have got a bit bigger over last few months. Other than that, no other eye symptoms. Moving on to past history, she was diagnosed to have thyrotoxicosis 6 months ago when she presented with typical symptoms such as weight loss, palpitations, and heat intolerance, and no thyroid disease prior to that. And this pregnancy was an unplanned pregnancy while on antithyroid drugs. So carbimazole was started 6 months ago at the time of diagnosis, and she was treated with a titration regime. However, her compliance was not that good, and after confirmation of pregnancy, the obstetrician has very correctly switched carbimazole to PTU, and she was on PTU 200 milligrams twice a day, and with a good compliance. She didn't have a family history of thyroid disease, and moving on to social history, she's a housewife from a poor socioeconomic background. Husband is a farmer, and she has an 8-year-old son. She's educated up to O-level, and her understanding about the disease and drug side effects was very poor, and she was a non-smoker. On examination, she had a BMI within normal limits. There was a diffuse goiter, no bruit, and she had mild proptosis, but no other soft tissue involvement. There was no redness or swelling of eyelids, conjunctiva, caruncle, or plica. So the clinical activity score for her eye disease was less than 3, and that means the eye disease is not active. And she was clinically euthyroid, and the rest of the system examination was unremarkable. So here is a fairly straightforward case. This is a Graves' disease with thyrotoxicosis. We know that orbitopathy is a characteristic sign of Graves' disease, and similarly, we see a diffuse goiter. And the problem is that she has been on carbimazole for 6 months and still on high dose carbimazole, and she has become pregnant, and it's an unplanned pregnancy. So what I want to really discuss is the management issues that we come across when we manage patients like this. So uncontrolled thyrotoxicosis during pregnancy can cause several maternal and fetal complications. So if we look at the mother, it can cause gestational hypertension, preeclampsia, eclampsia, placental abruptions, congestive heart failure, arrhythmias, and it can precipitate thyroid storm. If we take the fetus, thyrotoxicosis can cause miscarriages, intrauterine deaths, preterm delivery, intrauterine growth restriction, fetal goiter, and fetal and neonatal thyrotoxicosis. So when it comes to management of thyrotoxicosis during pregnancy, the only option that we have is medical treatment and radioactive iodine treatment. I'm sure all of you know that radioactive iodine treatment is contraindicated during pregnancy, and surgery is generally avoided. The problem with treatment is that the antithyroid drugs, the thionamide drugs, are teratogenic. So the prevalence of congenital malformations among neonates whose mothers were exposed to these drugs during early pregnancy varies from like 4 to 8% depending on the studies. And both carbimazole and PTU are teratogenic. However, the teratogenicity is more severe with carbimazole. So carbimazole or methimazole embryopathy is a well-characterized entity, and here congenital malformations can occur in various systems. So in the skin, it can cause aplasia cutis, it can cause GI malformations like tetralogy of Fallot, esophageal atresia or Fallocales, vitamin intestinal duct, and cardiac malformations like ventricular septal defects and some dysmorphic faces. Whereas if you look at PTU, the malformations are generally milder. It can cause head and neck malformations like preauricular and branchial sinuses, cysts and fistulas, and renal malformations like renal cysts and hydronephrosis. Therefore, considering these risks, PTU is considered as the preferred treatment options during early pregnancy. And the PTU should be considered until 16 weeks of gestation, and thereafter you can either continue PTU or can be switched to carbimazole. If you look at American guidelines, they recommend switching to carbimazole after first trimester, and that is because mainly they are worried about liver toxicity associated with PTU. Even though it is rare, PTU can cause fulminant hepatic necrosis, which can be fatal sometimes. Therefore, we generally tend to switch PTU to carbimazole after first trimester. So the most important thing that I want to highlight from this presentation is that if you are seeing a patient with Graves' disease, a young woman, it is very important to discuss pregnancy-related issues with the patient. So it is important to discuss the timing of pregnancy. So we need to find patient's wishes. So if patient is not in a hurry to become pregnant, then best thing is to wait until patient goes into remission with antithyroid drugs. That means it will take about 1 to 2 years of treatment. Or at least she should wait until the disease stabilizes, until thyroid function stabilizes with a small dose of carbimazole, like 5 or 10 milligrams per day, and then you may switch carbimazole to PTU and let the woman become pregnant. If patient says that I want to become pregnant as soon as possible, then the best option would be to offer thyroidectomy. A word about radioactive iodine, like radioactive iodine treatment. After radioiodine treatment, it is better to wait at least 6 months, because it might take about 6 months for thyroid function to stabilize. And the other concern is that radioactive iodine treatment can increase TRAB levels, and TRAB can remain elevated for up to 2 years. So it is not a very good option if a woman is planning for pregnancy. The second thing is, if woman is not desiring pregnancy, then we need to advise about contraception. And we need to advise patient to have a reliable method of contraception. So sometimes, so as clinicians, it is our duty to educate our patients, give the relevant information so that our patients can make informed decisions regarding their pregnancy. However, these patients, they may not follow our instructions, contraception may fail, and in that case, patients can become pregnant while on carbimazole. If that happens, then we need to switch carbimazole to PTU as early as possible. And the major risk of birth defects occur during 6 to 10 weeks of gestation, and therefore, ideally, we should do this switching before 5 weeks to avoid or to minimize risk of birth defects. And the other thing is, like, we need to consider whether we really need to continue antithyroid drugs. So there may be a subset of patients in whom you could consider therapy withdrawal. So, for example, if your patient is having stable thyroid function while on a small dose of antithyroid drugs, the TRAB level is very low or negative, if the TSH is normal while on antithyroid drugs, if patient has been on antithyroid drugs for a long period of time, more than 6 months, with stable thyroid functions, and if there is no active orbitopathy, and if the goiter is not very large, then in such a patient, you may consider stopping antithyroid drugs if patient becomes pregnant. However, if you stop drugs, it is very important to monitor thyroid function very closely. This means monitoring of T4 levels, initially every 1 to 2 weekly during first trimester. So moving back to this patient, so when she came to us at 8 weeks of gestation, this is the thyroid function she had. So the free T4 is, you can see that it is within lower half of normal range, and TSH is within normal range. And she's on PTU 200 milligrams BD. So is this, so what is our target T4 and TSH levels in a pregnant woman? So these antithyroid drugs, they can cross the placenta and blocks fetal thyroid hormone production. And at a given dose of antithyroid drugs, the block of fetal thyroid is more effective than maternal thyroid. Therefore, to avoid fetal hypothyroidism, we need to maintain free T4 levels at upper limit of normal or slightly above upper limit of normal with the lowest possible dose of antithyroid drugs. So in other words, we are keeping mother with slightly thyrotoxic. And TSH should not be normalized. TSH should be slightly suppressed. Like we should keep it between 0.1 to 0.4, that range. And thyroid functions should be closely monitored. After dose adjustments, T4 should be done like 2 to 4 weekly. And if patient is stable on antithyroid drugs, if thyroid function is stable, T4 can be checked 4 to 6 weekly. So this patient, here you can see that we have reduced the PTU dose, and now she is having pre-T4 levels slightly above upper limit of normal, and PTU was continued until 16 weeks of gestation. And it is very important to educate the patient regarding side effects. Now, these antithyroid drugs, they can cause minor side effects and major side effects. So the worry is this major side effects, even though these side effects are rare, it is very important to educate the patient regarding side effects. So if a patient is on PTU, we know that it can cause hepatotoxicity. So we need to do the baseline liver function tests, and when generally we monitor transaminases initially monthly for first 3 months. And then it is very important to educate about the risk of agranulocytosis, what symptoms to look out for, and what to do if they develop those symptoms. So just to mention about this agranulocytosis, agranulocytosis is absolute neutrophil count less than 500 per 500 cells per milliliter, and we generally stop antithyroid drugs if the neutrophil count falls below 1000. So if agranulocytosis occurs, it tends to occur early, but it can occur at any time during the course of the disease. So generally, we need to advise patient to check full blood count as soon as possible within first 24 hours if they develop symptoms like fever, sore throat, or mouth ulcers. And they have to stop medication and get the full blood count checked. And we usually write instructions to general practitioner or whoever the doctor who is going to see the patient. And this patient, after 16 weeks, PTU was switched to carbimazole. And now this patient, while on carbimazole, here you can appreciate that this patient has required carbimazole right up to third trimester, 34 weeks. And you can see that the dose of carbimazole, the requirement has decreased over time. So the next question is, what is this patient's risk of developing fetal or neonatal thyrotoxicosis? So going back to basics, we know that Graves' disease is an autoimmune disease due to formation of thyrotropin receptor antibodies, or TRAB. And TRAB mainly acts on the thyroid and causes diffuse enlargement and thyrotoxicosis. It can also act on other tissues like on the orbit and can give rise to orbitopathy. And when it acts on the skin, can give rise to dermopathy. And TRAB can cross the placenta and enters fetal circulation and can give rise to fetal goiter and thyrotoxicosis. And it can remain in the neonatal circulation for several months and can cause neonatal thyrotoxicosis. So if you look at natural history of Graves' disease during pregnancy, just like any other autoimmune disease, Graves' disease, generally the activity level goes down during pregnancy. And it is due to the immunosuppressive state of the pregnancy. And during postpartum period, there is a high risk of relapse due to this immune rebound phenomenon, just like any other autoimmune disease. So we generally expect the TRAB levels to reduce or goes down as pregnancy advances. So maternal TRAB can cross the placenta and stimulates the fetal thyroid after formation of the fetal thyroid, which happens at around 12 weeks of gestation. However, the fetal thyroid becomes responsive to maternal TRAB. In other words, the placental permeability to maternal TRAB increases after 20 weeks. So generally, the risk of neonatal or fetal Graves is increased after 20 weeks of gestation. And we know TRAB can cause a goiter and thyrotoxicosis. So the fetal characteristics of Graves include tachycardia, goiter, and accelerated bone maturation. And fetal complications include intrauterine growth restriction, oligohydramnios, cardiac failure, hydrops vitalis, and intrauterine death in untreated cases. So if you look at guidelines, like American Thyroid Association guideline, they recommend monitoring of TRAb levels during pregnancy to get an idea about the risk of developing fetal or neonatal thyrotoxicosis. So it is recommended to check TRAb during early pregnancy. If it is positive, to recheck during second trimester around 18 to 22 weeks, and if it is positive at that time, to recheck at around 30 to 34 weeks during third trimester. So studies have shown that TRAb levels at around 20 weeks, like 20 to 30 weeks, if TRAb levels are significantly elevated, that is, if the levels are more than 3 times upper limit of normal, then that increases the risk of developing fetal Graves' disease. And if TRAb levels are persistently raised during second half of pregnancy, then the risk of neonatal Graves' disease is high. High in the sense the risk is like 20%. So, which patients needs fetal surveillance for thyrotoxicosis? So, one is elevated TRAb, and second one is uncontrolled thyrotoxicosis during second half of pregnancy. So, studies have shown if mother is requiring antithyroid drugs to treat thyrotoxicosis during second half of pregnancy, then the risk of developing fetal and neonatal thyrotoxicosis is high. So this sort of patients need fetal surveillance. And you know that in our setup, we don't have access to TRAb. It's not available at government sector, and some patients can't afford to do it. So therefore, we have to go only by this ultrasound scan. So in ultrasound at experts' hands has a very high sensitivity and specificity to diagnose fetal Graves. So we generally look for presence of a goiter, presence of tachycardia, and presence of growth restriction, and low amniotic fluid index and growth parameters. So ultrasound surveillance, the ultrasound should be repeated every 4 to 6 weeks. So moving back to our patient, now here you can appreciate, based on what I have just discussed, this is a patient requiring antithyroid drugs even during second half of pregnancy, and therefore this patient has a high risk of developing fetal and neonatal thyrotoxicosis. So we did the fetal surveillance with ultrasound, and throughout the gestation, fetal surveillance was unremarkable. And so a few words about the neonatal thyroid function. So if a woman with Graves' disease is having uncontrolled thyrotoxicosis or is having elevated TRAb during pregnancy, the neonatal thyroid function can be either euthyroid or neonate can be hyperthyroid if neonate has maternal TRAb in the circulation, or neonate can be hypothyroid if mother is undertreated. Neonate can develop central hypothyroidism. If mother is overtreated with antithyroid drugs, neonate can develop hypothyroidism. Or if mother is having predominant inhibited TRAb, that again can cause hypothyroidism in the neonate. So generally, if we are treating mother with antithyroid drugs, at time of delivery, the neonatal thyroid function can be normal. But when the neonate metabolize and excrete the maternal antithyroid drugs, the neonatal T4 will increase. Therefore, it is recommended to monitor neonatal thyroid functions closely, and thyroid function should be rechecked between day 4 and day 7 to detect neonatal thyrotoxicosis. So going back to our patient, actually our patient was lost for follow-up after 34 weeks of gestation. Even though we have discussed everything and we have given all these plans, we were not aware of the outcome. However, she returned to clinic after 1 year after delivery. And then she said there were no complications in the neonate. So no malformations and no neonatal thyrotoxicosis. However, she was on a small dose of antithyroid drugs that we prescribed at 34 weeks. She was continuing that, and she was thyrotoxic with very high T4 levels at 1 year after follow-up. So sometimes these patients do not adhere to all our instructions and our treatment. So I would like to mention a bit about management of Graves' disease in patients who are in remission during pregnancy. So if a woman has received antithyroid drugs, and if a woman is in remission, and if woman becomes pregnant, we know that generally the thyroid function gives us an idea about the TRAB levels or the disease activity. So this sort of women, if they are in remission, we don't need to monitor TRAB levels. But however, we need to monitor thyroid functions at least once in each trimester and also postpartum among these women. So what if a woman has undergone thyroid ablative therapy in the past? So if a woman with Graves' disease has undergone surgery or radioactive iodine treatment in the past, then we can't go by the thyroid function. So these patients are generally on thyroid replacement treatment. So this graph shows what happens to TRAB levels after receiving various treatment options. So you can appreciate that the top line is TRAB levels after radioiodine treatment. So generally after radioiodine treatment, TRAB levels goes up and it can remain elevated up to 2 years. And but generally with surgery and medication, TRAB levels usually goes down with time. These women need monitoring of TRAB during pregnancy. At least we need to do it at high risk period, at like 20 to 30 weeks. That period we should do the TRAB levels. If it is not possible, we need to do the fetal surveillance to detect fetal thyrotoxicosis among these women. So with that, I would like to thank all of you for your participation. Thank you very much.
Thank you very much, Dr. Lalana, for very interesting and very informative presentation. Now we are coming to the Q&A session. Let me to check whether there are, yes, actually we couldn't receive any questions, and there are no questions in the Q&A box. And so may I ask a question from Dr. Gayani? Dr. Gayani?
Yes.
Yeah. In your patient, he presented with the recurrent pancreatitis.
Yes.
And I have seen that investigation shows the stone in the pancreatic duct. So is it the possible cause for the recurrent pancreatitis for this patient? Or?
Yes, the answer is Dr. Rohita here. At the moment, that is the most possible cause, because most of the patient with RAP is recurrent acute pancreatitis. Yeah. I think the gastroenterologist will agree that the most common is the gallstones, and then the malignancies and the ampulla of Vater, some lesions, and then there should be some sort of obstruction in the background of non-hypercalcemic, non-hypertriglyceridemic patient. At the moment, I'm not 100% sure that it is the cause, but the thing is that MRCP was unable to find out any other cause. But the thing is that anyway, surgeons have already planned for an ERCP. Actually, this has not happened acutely because he was recovering from chronic pancreatitis, acute pancreatitis. So hopefully we might be able to find out whether it's the exact cause, but at the moment, that is the most possible explanation.
Okay, thank you very much, Dr. Gayani. And also, may I ask a question from Dr. Lalana Devi? And Dr. Lalana, and you know, one of the main complications of antithyroid drug is agranulocytosis. If our patient develop agranulocytosis with antithyroid drugs in pregnancy, so what is the treatment option?
Yes. So if a woman develops agranulocytosis during pregnancy, then we are limited with available medical treatment options. So generally, the things that we can try, the medical treatment options that we can try include steroids like prednisolone, can be given. And then we can try drugs like polystyramine and iodine, the gold's iodine. So these drugs can be tried, but we know that the efficacy of these drugs it's not as effective as thionamide drugs. Therefore, in such situations, we might have to go for surgery. So surgery can be considered during second trimester if a woman is having having major adverse reactions to antithyroid drugs, where antithyroid drugs are contraindicated.
Okay. Thank you very much, Dr. Lalana. And there's one question in the Q&A box. That questions go to Dr. Gayani. And the question is, if there is hypertriglyceridemia and pancreatitis, what is the first line fibrate?
Actually, I really don't know the exact answer. I think the endocrinologist will give a better opinion, but as according to my experience, even in the other countries, it seems that fenofibrate seems to be the first line therapy. And in my foreign training, that was the commonest drug used in these type of situations, but I'm not 100% sure about it.
Yes. Okay. Thank you very much, Dr. Gayani. And in the absence of any more questions, let me to wind up the sessions today. First, I would like to thank two speakers, Dr. Gayani Samaratunge and Dr. Lalana Devi Ranasinghe, for accepting our invitations to share their experiences with us. Also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor Merck Pharmaceuticals for their continuous support, and all virtual participants who joined with us today. Thank you.